Hi everybody, my name is Rosina Chavasco, and today we will be discussing the essential and conditionally essential nutrients. We will first start off with vitamins. Listed here are the objectives of the lecture. You should be able to differentiate between water and fat-soluble vitamins, discuss the function of each vitamin, introduce the names, dietary sources, and the recommended intakes of each, to evaluate the potential causes and impact of deficiency of each vitamin, and to analyze the safety considerations. Vitamin and mineral supplements should be used as adjuncts to a balanced diet, not as substitutes for nutritious food. The best method for avoiding nutritional deficiencies is to consume a balanced diet each day that includes foods from sources high in several essential nutrients. To guide consumers in selecting a balanced diet while allowing individual preferences, the U.S. Department of Health and Human Services and the U.S. Department of Agriculture advise consumers to regularly choose a variety of nutrient-dense foods in moderate portion sizes, as shown in my plate. Each food group provides a significant source of essential nutrients. Vitamins are nutrients that cannot be synthesized in the body. They must be obtained from the diet. They are used as both dietary supplements and therapeutic agents to treat deficiencies or other pathologic conditions. The dietary reference intake are reference values of daily nutrient intake recommended by the Food and Nutrition Board of the Institute of Medicine of the National Academies. The DRIs include 4 reference categories: estimated average requirements, recommended daily allowance, adequate intakes, and tolerable upper intake levels. The estimated average requirement is defined as intake levels for nutrients estimated to meet the needs of half of the healthy individuals in a particular life stage and gender group. The recommended daily allowance is the average daily dietary intake level that is sufficient to meet the nutrient requirement of nearly all healthy individuals in a particular group. Adequate intake is defined as values based on observed or experimentally determined approximations of nutrient intake by a group of healthy people. And lastly, tolerable upper intake levels are the highest dose of nutrient that may be consumed daily with the risk of adverse drug reactions in the general populations. As many of you know or personally have experienced, it can be very overwhelming to walk down a pharmacy aisle looking for a vitamin or mineral supplement. As pharmacists, we have the unique ability to counsel patients regarding the potential difference between a product's actual content and its label, hopefully making it a little bit easier for the patient to choose a product that's best for them. The potential for labeling inaccuracy exists because dietary supplements are not assessed for compliance or standardization by any government agency. However, the United States Pharmacopoeia provides a dietary supplement verification program that allows product labeling with the USP mark if the tested product meets specific requirements. This includes verification of the product's ingredients and amounts, effective disintegration and dissolution for absorption, absence of harmful contaminants, and safe, sanitary, well-controlled manufacturing. So when you start making recommendations, don't forget to advise patients to look for the USP mark on vitamin and mineral supplement labels. However, if no brand with the USP mark can be found for a specific product, consider a brand whose other products do bear a USP mark, as that's usually a good indication of good standards. The vitamins are classified into 2 broad categories: fat-soluble and water-soluble. Vitamins A, D, E, and K are fat-soluble, and a useful mnemonic to remember this group is all dogs eat kibbles, which you can see a little picture that I added there. The water-soluble vitamins are listed on the right and include vitamin C and the B-complex vitamins. We will begin with the fat-soluble vitamins. As the name suggests, these vitamins are soluble in lipids and are usually absorbed into the lymphatic system before passing into general circulation. Their absorption is facilitated by bile. These vitamins are stored in body tissues, so ingestion of excessive quantities may be toxic. Vitamin A refers to compounds that includes retinoids and carotenoids. In healthy adults, more than 90% of the body's supply of vitamin A is stored in the liver. Because of the generous reserve, there is a minimal risk of deficiency during short-term periods of inadequate intake or fat malabsorption. Vitamin A is essential for normal growth and reproduction, normal skeletal and tooth development, synthesis of the glycoproteins necessary to maintain normal epithelial cell mucus secretions, which is vital in the body's defense against bacterial infections in the upper respiratory system. Lastly, vitamin A is vital for proper functioning of the eye, especially the conjunctiva, the retina, and the cornea. Vitamin A is known as retinol because it produces the pigments in the retina of the eye. Vitamin A deficiency is rare in well-nourished populations. Conditions that compromise fat absorption, such as celiac or Crohn's disease, as well as therapy with corticosteroids, may cause excessive excretion of vitamin A. In the United States, vitamin A deficiency occurs more often from diseases of fat malabsorption than from malnutrition. Infants and young children are more susceptible of vitamin A deficiency because they have not established the necessary reserves like adults have. If patients do not get enough vitamin A, they are mostly at an increased risk for eye problems, which is the earliest symptom. These include reversible night blindness and then non-reversible corneal damage known as xerophthalmia. Lack of vitamin A can also lead to hyperkeratosis or dry, scaly skin, loss of appetite, impaired taste and smell, and impaired equilibrium. Listed here are the DRI values for vitamin A, which are measured in micrograms of retinal activity equivalents. The tolerable upper limit of 3 milligrams per day in adults has been established on the basis of congenital birth defect risks and liver abnormalities associated with vitamin A toxicity. Vitamin A comes from animal sources such as liver, milk fat, and eggs. It's important to keep note that many of these sources are high in saturated fat and cholesterol. Vitamin A is also found in the fruits and vegetables listed here. The more intense the color of a fruit or vegetable, the higher the beta-carotene content. Vegetable sources of beta-carotene are fat and cholesterol-free. The absorption will be improved if these sources are consumed with fat. Since vitamin A is stored in the body, high doses of it can lead to a toxic syndrome known as hypervitaminosis A. Risk increases with conditions in which vitamin A is not excreted and in taking several supplements containing multiple sources of vitamin A. Headache is a predominant symptom, and it may be accompanied by diplopia, nausea, vomiting, vertigo, fatigue, or drowsiness. Treatment consists of discontinuing vitamin A supplementation, which should result in complete recovery. Although beta-carotene toxicity is not likely, eating large amounts of carrots in the daily diet may result in carotenemia, which can produce a yellow skin hue. Pregnant women or women of childbearing age should avoid doses above the DRI because of the teratogenic risk. It's important to advise these women to carefully evaluate the total vitamin A content of all dietary supplements and fortified foods consumed regularly. Now we move on to discuss vitamin D, which is also known as calciferol. Vitamin D has two main forms. Vitamin D2, known as ergocalciferol, is synthesized by plants and used as a food additive. Vitamin D3, also known as cholecalciferol, is a naturally occurring form and synthesized in the skin by exposure to direct sunlight and obtained in the diet. Vitamin D is a prohormone with several active metabolites that act as hormones. Activation of vitamin D requires hydroxylation by both the liver and the kidneys, which you can study here in the diagram. The conversion of calcitriol is regulated by its own concentration, parathyroid hormone, and serum concentrations of calcium and phosphate. Therefore, either renal or hepatic dysfunction may result in clinical manifestations of vitamin D deficiency, including hypocalcemia unresponsive to non-prescription vitamin D supplementation. These patients require a hydroxylated vitamin D preparation available only by prescription. Vitamin D is needed for normal absorption of calcium and phosphorus. It helps put these minerals into bones and teeth. This makes bones stronger and reduces risk for bone fractures. Vitamin D also helps keep the immune system functioning normally so our bodies can resist some types of diseases. Deficiencies of vitamin D may result from various reasons: inadequate exposure to sunlight, GI disease, chronic renal failure, hereditary disorders of vitamin D metabolism, obesity or gastric bypass therapy, or long-term therapy with anti-epileptic medications such as phenytoin, carbamazepine, and primidone. Older patients' reduced skin exposure and aging skin may not synthesize vitamin D efficiently, and the converting process that takes place in the liver and kidneys may also be compromised. Signs and symptoms of vitamin D deficiency are reflected as calcium abnormalities, specifically those involved with bone formation. The classic vitamin D deficiency state is rickets. Although the incidence of rickets in the U.S. is rare, it is not absent. Rickets is a disease that causes the bones to become soft and bend, and most likely to occur in children who abstain from milk and in infants breastfed by mothers who receive an inadequate intake of vitamin D. Osteoporosis with an increased risk of fracture also occurs. Vitamin D deficiency also has been associated, but not indicating causation, with muscle weakness, an increased risk of falls, an increased risk of cardiovascular disease, and psychiatric disorders and certain cancers. Most people obtain the adequate intake for vitamin D from dietary sources and from exposure to sunlight. Those that are routinely exposed to the sun do not have a dietary requirement for vitamin D. For those that are limited to sunlight exposure, one must take careful consideration of vitamin D intake from dietary sources. The current upper limit for vitamin D is 4,000 international units a day, which may be increased in the near future. Data gathered from recent use of prescription-only high-dose vitamin D supplements, which is 50,000 units per week, suggests such doses are safe and necessary to achieve adequate serum concentrations. Here at USF, doctors are prescribing some of the indoor practicing student athletes 50,000 units per week to help keep up with their health, training, and performance. It's important to note, though, that these high doses should not be recommended for self-care without further evaluation. Vitamin D is FDA approved for the treatment of hypocalcemia and hypophosphatemia associated with hypoparathyroidism. Prescription vitamin D analogs are FDA approved for the treatment of secondary hyperparathyroidism in patients with chronic renal failure. There are foods that naturally have vitamin D, including eggs and fatty fish such as salmon, tuna, and sardines. Vitamin D can also be obtained from fortified foods, including milk and other dairy products such as cheese. In the United States, milk and milk products are the major sources of dietary vitamin D, because milk is routinely supplemented with 100 units of vitamin D per cup. Many of you may be familiar with the Got Milk advertising campaign, which featured celebrities with the infamous milk mustache, encouraging the consumption of milk. Getting too much vitamin D can be harmful. Signs of toxicity include anorexia, hypercalcemia, which presents as confusion, disorientation, and problems with heart rhythm. Excess vitamin D can also cause kidney stones and damage to the kidneys, and increased risk of certain types of cancers such as breast, prostate, and esophageal cancers. Most cases of vitamin D toxicity happen when someone overuses vitamin D supplements. Excess sun exposure doesn't cause vitamin D poisoning because the body limits the amount of this vitamin it produces. We will now discuss vitamin E, which is also known as tocopherol and tocotrienol, which are compounds that occur naturally in plants. Vitamin E functions primarily as an antioxidant, protecting cellular membranes with selenium and vitamin C from oxidative damage or destruction. Vitamin E may also have a role in heme biosynthesis, steroid metabolism, and collagen formation. Vitamin E helps widen blood vessels so that blood can easily get through them. It also prevents blood from clotting inside the vessels. Vitamin E deficiency is extremely rare, but may occur in premature infants with very low birth weight, which is more common in developing countries, and patients who do not absorb fat normally. Vitamin E deficiency has been associated with symptoms of peripheral neuropathy, intermittent claudication, which is a cramping pain in the leg, muscle weakness, and hemolytic anemia. The RDA for vitamin E is reported as milligrams of alpha tocopherol. 1 milligram of alpha tocopherol vitamin E is equivalent to 1.49 international units. Most food and nutrient supplement labels list vitamin E content in international units. The average diet contains approximately 3 to 15 milligrams per day of vitamin E. Therefore, large doses in excess of the DRI are not necessary unless the patient is experiencing fat malabsorption. The tolerable upper limit is 1,000 milligrams per day. The FDA-approved use of vitamin E is for prevention and treatment of hemolytic anemia associated with deficiency. Numerous foods provide vitamin E. Vegetable oil, such as wheat germ, nuts, and seeds, are among the best sources of alpha tocopherol, and significant amounts are available in green leafy vegetables, such as spinach and broccoli, and fortified cereals. Most vitamin E in American diets is in the form of gamma tocopherol from soybean, canola, corn, and other food products. Many adults take relatively large amounts of vitamin E for months to years without any apparent harm. However, high doses of vitamin E may increase the risk of bleeding, particularly for adults who are also taking an anticoagulant, especially warfarin, which makes blood less likely to clot. Occasionally, adults who take very high doses develop muscle weakness, fatigue, nausea, and diarrhea. Phytonadione, which is known as vitamin K1, is present in many vegetables. Menaquinone, vitamin K2, is a product of colonic bacterial metabolism. Menadione, which is vitamin K3, is a synthetic compound that is 2 to 3 times as potent as a natural vitamin K. Vitamin K is necessary for the synthesis and activation of clotting factors that help control bleeding and for the normal clotting of blood. It also activates anticoagulation proteins C and S in the liver. It is also needed for healthy bones and other tissues by activating osteocalcin, which appears to play a role in bone mineralization and the prevention of osteoporosis. In healthy adults, vitamin K deficiency is uncommon because many green vegetables contain vitamin K, which we will discuss in one of the upcoming slides. And bacteria in the intestines produce vitamin K, covering the body's requirement for vitamin K. Interference with bioproduction or secretion may contribute to vitamin K deficiency, because vitamin K absorption in the small intestines requires bile. Disorders that impair fat absorption, such as cystic fibrosis and bowel resections, reduce the absorption of vitamin K. And lastly, certain drugs, including chronic broad-spectrum antibiotic therapy, can also cause deficiency. The main symptoms of vitamin K deficiency is bleeding, either into the skin, causing bruises from the nose, from a wound in the stomach, or in the intestines. Sometimes bleeding in the stomach causes vomiting with blood. Blood may be seen in the urine or stools may be tarry black. It can also be demonstrated clinically by prolonged prothrombin time. Some trials have shown that there is an increased risk of osteoporotic fractures with lower intake of vitamin K. The DRI values for vitamin K are listed here for you in the table. A tolerable upper limit for vitamin K has yet to be established. Vitamin K1 is FDA approved for use in neonates at birth, at one dose of 1 milligram, to prevent the risk of bleeding within the brain after delivery. This dose is necessary because only small amounts of vitamin K pass from the mother to the fetus during pregnancy and during the first few days after birth. The newborn's intestines has not yet acquired bacteria to produce vitamin K for themselves. Other approved uses include the prevention and treatment of hypoprothrombinemia caused by drug-induced deficiency and the treatment of hemorrhage. The most common sources of vitamin K in the U.S. diet are spinach, kale, broccoli, and iceberg lettuce, and fats and oils, particularly soybean and vegetable oil. Vitamin K can have a serious and potentially dangerous interaction with anticoagulants such as warfarin, which antagonizes the activity of vitamin K, leading to the depletion of vitamin K-dependent clotting factors. People taking warfarin need to maintain a consistent intake of vitamin K from food and supplements because sudden changes in vitamin K intakes can increase or decrease the anticoagulation effect. That wrapped up the discussion on oil-soluble vitamins, and now we will begin our discussion on water-soluble vitamins. Water-soluble vitamins are generally not stored in the body, and vitamin C, also known as ascorbic acid, is the most easily destroyed of all the vitamins because of its sensitivity to heat, oxygen, and alkaline environments. It is a relatively simple compound with powerful antioxidant activity that serves to protect the capillary basement membrane. Vitamin C has been called the fresh food vitamin because most of the daily vitamin C intake is derived from vegetables and fruit sources. Vitamin C is necessary for the biosynthesis of hydroxyproline, a precursor of collagen, osteoid, and dentin. This means it helps maintain the formation, growth, and repair of bone, skin, and connective tissue, and maintains healthy teeth and gum. This vitamin also assists in the absorption of non-heme iron from food by reducing the ferric iron in the stomach to ferrous iron, which is needed to make red blood cells. Studies have found that large doses of vitamin C, from 500 to 1,000 milligrams per day, have been promoted to prevent and treat the common cold. This is the main ingredient in the popular OTC product Emergency. However, these claims are still largely unsupported by well-designed controlled clinical trials. Consumption of 5 servings or more of fruit and vegetables daily, equivalent to over 200 milligrams of vitamin C, has been associated with the lower incidence of cancer, heart disease, stroke, and certain eye diseases. Again, more data and studies are still needed to support these claims. In adults, vitamin C deficiency usually results from a diet low in vitamin C. For example, vitamin C deficiency may result from a diet deficient in fresh fruits and vegetables. Also, cooking can destroy some of the vitamin C in food. Vitamin C deficiency may result in feeling tired, weak, and irritable. Other characteristics include capillary hemorrhages and petechiae, swollen hemorrhagic gums, and bone changes. Deficiency may also impair wound healing. Profound dietary deficiency can eventually lead to scurvy, which I'll further delve into in the next slide. Scurvy is rare in the United States because it develops only with chronically inadequate consumption of vitamin C. Scurvy is characterized by weakening of collagenous structures, resulting in widespread capillary bleeding. Bleeding gums and loosening of the teeth are usually the earliest signs of clinical deficiency. Infants who are fed artificial formulas without vitamin supplements may develop symptoms of scurvy. In adults, however, scurvy occurs after 3 to 5 months of a diet free of vitamin C. Practitioners are rarely confronted with overt symptoms of vitamin C deficiency. As mentioned in the last slide, only 10 milligrams per day of vitamin C prevents scurvy. A normal diet containing fresh fruits and vegetables contains many times this amount. For smokers, supplementation of 100 to 125 milligrams per day has been recommended to counteract the damage that smoking causes to cells. The upper limit to vitamin C is 2 grams per day. Vitamin C is FDA approved for the use in the prevention and treatment of scurvy and to acidify the urine. Good sources of vitamin C include sweet, green, and red peppers, broccoli, tomatoes, potatoes, strawberries, and citrus fruits, of course including oranges. Megadoses of vitamin C may cause nausea, stomach cramps, diarrhea, and nephrolithiasis, which are kidney stones. Patients with diabetes, recurrent renal calculi, or renal dysfunction should also avoid prolonged use of high-dose vitamin C supplementation due to the damage that vitamin C causes to kidneys in high amounts. Here's a list of all the B vitamins. I'm going to go through them in the order of your book so it's easier to follow if you're reading your book and listening to the lecture at the same time. So we will begin with vitamin B12. Vitamin B12 is the most complex vitamin molecule, existing in several forms, all of which contain the element cobalt. Cyanocobalamin, the common pharmaceutical form of the vitamin, is the most stable of the cobalamins. Vitamin B12 is active in all cells, especially those in the bone marrow, the central nervous system, and the GI tract. It assists in the synthesis and transfer of single carbon units, converting homocysteine to methionine. Vitamin B12 is also required for red blood cell formation, neurologic function, and synthesis of DNA and cell division. Vitamin B12 is necessary for the metabolism of folates. Therefore, folate deficiency may be observed as a feature of vitamin B12 deficiency. Vitamin B12 also is necessary for the metabolism of lipids and the formation of myelin. Vitamin B12 is found almost exclusively in animal protein. Healthy individuals without dietary restriction rarely experience deficiency. Unlike most other vitamins, B12 is stored in substantial amounts, mainly in the liver, until it is needed by the body. If a person stops consuming the vitamin, the body's stores of this vitamin usually takes about 3 to 5 years to exhaust, so a pretty long time. Vegetarians who do not consume any animal products, including infants breastfed by vegetarian mothers, are also at risk for developing vitamin B12 deficiency. Long-term treatment with metformin can induce malabsorption of vitamin B12 as well, in as little as 3 months of metformin therapy. Vitamin B12 deficiency may be caused by malabsorptive conditions. Since absorption is a complex process, deficiency may occur in patients with conditions that affect it, including those with ileal diseases, intestinal resection, and gastrectomies. Patients older than 50 years old are also at an increased risk of deficiency that results from reduced gastric acidity, reduced intestinal motility, and the use of gastric acid-lowering agents. Additionally, atrophic gastritis, which affects 10 to 30% of older adults, also leads to deficiency. Deficiencies result in macrocytic anemia, whereas GI effects include glossitis and epithelial changes occurring along the entire digestive tract. As mentioned previously, vitamin B12 is necessary for the maintenance of myelin. Therefore, deficiencies produce many neurological symptoms such as paresthesia, peripheral neuropathy, unsteadiness, poor muscular coordination, mental confusion, agitation, hallucinations, and overt psychosis. An upper limit has not been established for vitamin B12. Oral forms can be used if the deficiency is caused by inadequate intake or malabsorption. Intramuscular or deep subcutaneous administration can achieve a more rapid replenishment to meet requirements if needed. Vitamin B12 is FDA approved for use in the treatment of pernicious anemia and vitamin B12 deficiency. Other approved uses include supplementation during periods of increased requirements, such as pregnancy, hemorrhage, malignancy, liver disease, and kidney disease. Patients who have undergone bariatric surgery, such as gastric bypass or a gastric sleeve, require lifelong vitamin B12 supplementation to prevent deficiency. Good sources of vitamin B12 include meats, especially beef, pork, liver, and other organ meats, oysters, clams, and milk. Excessive doses have not resulted in toxicity. However, non-deficient patients taking large quantities of the vitamin have reported no benefit. Absorption and utilization by the body can be compromised with the chronic use of certain medications, which include metformin, colchicine, anticonvulsants, ascorbic acid supplementation, antacid agents, and antibiotics. Now we will discuss vitamin B9, known as folic acid, which refers to the synthetic version of this vitamin found in nutritional supplements and in fortified foods. Folate refers to the naturally occurring form found only in food sources. Folate is essential for cell division, DNA production, and brain and spinal cord development. It is also used in the metabolism of various amino acids. Folic acid, whether contained in a nutritional supplement or consumed through dietary sources, is not biologically active and must undergo in vivo enzymatic conversion to the usable form. Many patients have a genetic polymorphism of the MTHFR gene that results in inadequate enzyme activity and inability to convert folic acid to its active form. The requirements for folic acid are related to metabolic rate and cell turnover. Increased amounts of folic acid are needed during pregnancy, lactation, and infancy. Other conditions include infection, hemolytic anemia, blood loss, and hypermetabolic states. Because folic acid deficiency has been associated with an increased risk of neural tube defects in newborns, supplementation for all women of childbearing age is recommended. Causes of folic acid deficiency include alcoholism, malabsorption, food fatism, and liver disease. Certain medications can cause deficiencies, including dihydrofolate reductase inhibitors such as methotrexate and trimethoprim, anticonvulsants, and sulfasalazine. Symptoms of folic acid deficiency include a sore mouth, diarrhea, and CNS symptoms, including irritability and forgetfulness. The most common laboratory identified feature of folic acid deficiency is megaloblastic anemia. The DRI values for folic acid are listed here. Folate is FDA approved for use in the treatment of megaloblastic anemias caused by folate deficiency. Folate is also approved for prevention of neural tube defects of newborns. All women of childbearing age should consume synthetic folic acid at a dose of 400 micrograms per day from fortified foods and/or dietary supplementation, in addition to the folate obtained from food. Higher requirements are needed during pregnancy and lactation. The supplemental dose of folic acid for correction of a deficiency in adults is usually 1 milligram per day, with doses larger than this not normally being necessary except in some life-threatening diseases. Folates are present in a wide variety of food sources and are heat labile. The folic acid content of food depends on how the food is processed. Here's a list of some of the dietary sources where one can obtain vitamin B9. Folic acid toxicity is virtually non-existent because of its water solubility and rapid excretion. Doses up to 15 milligrams per day have been given without toxic effect. High levels may mask B12 deficiency until neurological effects become irreversible. And several drugs, when taken chronically, may increase the need for folic acid supplements. Now we will go into vitamin B3, also known as niacin, with the physiologically active form known as niacinamide. Niacin and niacinamide are constituents of the coenzymes NAD and NADP. Niacin is a unique vitamin because humans can synthesize it from dietary tryptophan, with about 60 milligrams of tryptophan being equivalent to 1 milligram of niacin. Most individuals receive about 50% of their niacin requirement from tryptophan-containing proteins. The niacin coenzymes are electron transfer agents, in which they accept or donate hydrogen in the aerobic respiration of all body cells. Niacin also is used to decrease triglycerides and LDL cholesterol. Deficiency occurs mostly in alcoholics, poorly nourished geriatrics, and individuals on diets that severely restrict sources of niacin. It may also occur when large quantities of corn are consumed, as the niacin found in corn is unavailable for absorption. Isoniazid therapy in diseases with little tryptophan conversion, as in Hartnup disease and carcinoid tumors, also lead to B3 deficiency. Deficiency results in pellagra, with clinical findings including the 3Ds of dermatitis, diarrhea, and dementia, often accompanied by neuropathy and glossitis, which is a beefy red tongue, stomitis, and proctitis. Patients develop a characteristic rash in which the skin is hard and cracked with blackish pigmentation that is crusty and scaly. Lesions occur primarily on sun-exposed areas. Here I included pictures to give you a visualization of what pellagra looks like. Please take note of how the sun-exposed areas of the skin look, appearing thick, crusty, and darker. The recommended upper limit for niacin in adults is 35 milligrams per day, with the requirements increasing after a severe injury, infection, or burn, or when the patient has an acute illness. Both niacin and niacinamide are FDA approved for the prevention and treatment of pellagra, having patients take 150 to 500 milligrams a day in divided doses. Niacin, but not niacinamide, is also approved for adjunctive treatment of hyperlipidemia and hypercholesterolemia. Daily doses of 1 to 2 grams 3 times per day up to 8 grams a day of niacin are used to treat these conditions. High-dose niacin therapy should not be undertaken as self-care and should only be used under medical supervision. Listed here are the dietary sources for niacin, with liver having the best natural source. Niacinamide is associated with little toxicity. However, niacin toxicity can involve GI symptoms such as nausea, vomiting, and diarrhea, hepatotoxicity, skin lesions, tachycardia, and hypertension. Patients should be forewarned that therapeutic doses of niacin may cause flushing and a sensation of warmth, especially around the face, neck, and ears. This reaction is prevalent upon initiation of therapy and may be minimized with 325 milligrams of aspirin or 200 milligrams of ibuprofen, taken 30 to 60 minutes before the niacin dose. These side effects usually subside after 2 weeks. The extended release formulation of niacin may cause less flushing, but unfortunately it has a greater risk of gastric and hepatic side effects. If niacin does cause GI upset, it can be taken with meals. Due to the adverse GI effects, high doses of niacin are contraindicated in patients with gastritis or peptic ulcer disease. Niacin should also be used carefully in patients with asthma as it can provoke the release of histamine. Now we'll move on to vitamin B6. This water-soluble vitamin exists in 3 equally effective forms: pyridoxine, pyridoxal, and pyridoxamine, with pyridoxine being the most often used form in the vitamin formulations. Pyridoxine serves as a cofactor for more than 60 enzymes, including transaminases and hydroxylases. It is important in heme production and homocysteine metabolism. It is also involved in glucogenesis, glycogenolysis, and immune function. Limited data supports B6 in treatment of migraine headaches and nausea of pregnancy. However, the use of pyridoxine is generally undertaken under medical supervision. Although it lacks clinical research evidence, it has also been suggested as a potential treatment of carpal tunnel syndrome and PMS and depression. Causes of vitamin B6 deficiency include alcoholism, severe diarrhea, food fatism, malabsorptive syndromes, isoniazid, and genetic diseases. The symptoms of severe vitamin B6 deficiency in infants include irritability and convulsive disorders. Symptoms in adults are difficult to distinguish from symptoms of niacin and riboflavin deficiencies. Symptoms include pellagra-like dermatitis, oral lesions, peripheral neuropathy, scaliness around the nose, mouth, and eyes. Serious deficiency symptoms include convulsions, peripheral neuritis, and sideroblastic anemia. The upper limit for this vitamin is 100 milligrams per day for adults. Although this is a limit, treatments require higher amounts as listed here. The FDA-approved use of this vitamin is for treatment of vitamin B6 deficiency, including drug-induced deficiency as seen with isoniazid. For each 100 milligrams of isoniazid, it's recommended to take 10 milligrams of pyridoxine. Listed here are some dietary sources of pyridoxine. It is important to note that cooking destroys some of the vitamin B6 in the sources. Vitamin B6 may be toxic in high doses. Severe sensory neuropathy can occur along with inhibition of prolactin at doses from 200 to 600 milligrams. Prenatal vitamins, which contain about 1 to 10 milligrams per dosage unit, do not appear to have a significant antiprolactin effect. Now we'll go into the discussion of vitamin B1, which is also known as thiamine. It is available in oral and injectable dosage forms. Thiamine is necessary for myocardial function, nerve cell function, and carbohydrate metabolism to produce energy. The amount needed increases with increased carbohydrate consumption. Thiamine's active form, thiamine 5-phosphate, is important for biochemical conversion cycles, such as the oxidative decarboxylation of pyruvic acid and in the formation of acetylcoenzyme A, which enters the Krebs cycle. Thiamine deficiency in the United States is found primarily in alcoholics. Alcoholics often substitute alcohol for food, not consuming enough thiamine. Alcohol also interferes with the absorption and metabolism of this vitamin and may increase the body's need for thiamine. Some other main causes of thiamine deficiency are generally inadequate diet, malabsorptive symptoms, prolonged diarrhea, chronic furosemide therapy, increased requirements such as pregnancy, and food faddism. Thiamine deficiency, also known as beriberi, may present with neuromuscular symptoms such as peripheral neuritis, weakness, and Wernicke's encephalopathy. Cardiac dysfunction may also be observed, possibly accompanied by edema, tachycardia on minimal exertion, an enlarged heart, and electrocardiographic abnormalities. Listed here are the DRI values for thiamine. There is no defined upper limit. Symptomatic patients are preferably treated with intravenous thiamine. Long-term oral supplementation may be recommended for patients at continued risk of deficiency, including alcoholic patients and those prescribed high-dose furosemide therapy. The FDA-approved use of thiamine is for the treatment of thiamine deficiency. Good sources of thiamine include legumes, dried yeast, whole grains, enriched cereals, and meat, especially pork and liver. It's important to note that the thiamine content of food can be destroyed by heat, oxidation, and an alkaline environment, but it is stable through frozen storage. The kidney easily clears excessive thiamine intake, and oral doses of 500 milligrams have been found to be non-toxic. As mentioned previously, diuretics have been shown to increase the urinary excretion of thiamine. Therefore, patients on chronic diuretic therapy, such as those with congestive heart failure or hypertension, should be recommended supplementation with 100% of the DRI for thiamine. And now we will go into discussing vitamin B5, also known as pantothenic acid, which is essential to all forms of life. Its name originates from the Greek word pantos, meaning everywhere, as it occurs widespread in foods of plant and animal origin and is found throughout all living cells. Pantothenic acid is a precursor of coenzyme A product that plays a primary role in cholesterol, steroid, and fatty acid synthesis. It is also important for acetylation reactions and the formation of citric acid for the Krebs cycle. Pantothenic acid is crucial in the intraneural of acetylcholine and gluconeogenesis, synthesis and degradation of fatty acids, synthesis of sterols, steroid hormones, and porphyrins, and the release of energy from carbohydrates. Because pantothenic acid is contained in many foods, deficiency states are rare and hard to detect. In malabsorption syndromes, it is difficult to distinguish pantothenic acid deficiency symptoms from other deficiencies. Symptoms of this deficiency include somnolence, fatigue, cardiovascular instability, abdominal pain, and paresthesia of hands and/or the feet, followed by hyperreflexia and muscular weakness in the legs. Here are the dosing and daily requirements of vitamin B5. Currently, there is no tolerable upper limit that is defined. Administration of pharmacological doses reverses the deficiency symptoms we previously discussed. It is used to eliminate burning feet syndrome. There is also no known toxic concentration, making it relatively safe. The richest vitamin B5 sources are yeast and organ meats, such as liver, kidney, heart, and the brain. But eggs, milk, and vegetables, legumes, and whole grain cereals are more common sources. Moving on to vitamin B2, it is known as riboflavin. Riboflavin is essential for cellular growth and maintenance of vision, mucous membranes, skin, nails, and hair. Riboflavin is involved in numerous oxidation and reduction reactions, including the cytochrome P450 reductase enzyme system involved in drug metabolism. Riboflavin deficiency, although rare, may be caused by inadequate intake, alcoholism, or malabsorptive syndromes. Deficiency may occur during pregnancy as well. Early signs of riboflavin deficiency may involve ocular symptoms as the eyes become light sensitive and easily fatigued. The patient may develop blurred vision, itching, watering, sore eyes, and corneal vascularization, which causes a bloodshot appearance of the eye. Clinical findings of more advanced deficiency include stomatitis, seborrheic dermatitis, and magenta tongue. A tolerable upper limit has not been established for riboflavin as well. The need for riboflavin appears to increase in time of cell growth, as in pregnancy and wound healing. Its absorption is enhanced when taken with food. The FDA-approved use of riboflavin is in the prevention and treatment of riboflavin deficiency. Listed here are some dietary sources in which riboflavin can. Vitamin B2 doesn't really have a known toxicity. It's important to note that it may cause a yellow-orange fluorescence or discoloration of the urine, which is completely normal. Going into vitamin B7, it is known as biotin. It is necessary for various metabolic functions, including carbohydrate, fat, and amino acid metabolism. There are several biotin-dependent enzymes that are known to exist as well. Biotin deficiency in humans is rare but can be caused by excessive weight loss with intense caloric restriction, and those with chronic malabsorption may not be able to obtain adequate biotin. Oddly, ingesting a large number of raw egg whites prevents biotin absorption because raw egg whites contain avidin, a protein that binds biotin. This isn't a problem when cooking your eggs, as the heat denatures avidin, making it unable to interfere with biotin absorption. Deficiency appears to result in symptoms of nausea, vomiting, lassitude, muscle pain, anorexia, anemia, and depression. Some physical findings include dermatitis, a grayish color of the skin, and glossitis. Hypercholesterolemia and cardiac abnormalities may also occur. Here's the dosing and the daily requirements for biotin. There has not been a tolerable upper limit established. I attached a picture of a common product that's sold in the pharmacy. This one is Nature's Bounty Hair, Skin, and Nails. This one in particularly has 3,000 micrograms of biotin. A lot of patients do come by the pharmacy looking for this, as they claim it really does help them, so that's something to keep in mind. Listed here are some dietary sources for biotin. As most biotin is stored in the liver, eating animal liver is one of the simplest ways to increase biotin in a diet. The biotin content of food can vary. For example, plant variety and season can affect the biotin content of cereal grains, and certain processing techniques, such as canning, can reduce the biotin content of foods. Vitamin B4 is also known as choline, which is contained in most living cells and in foods. In addition to being found in food, choline is synthesized in the body. Therefore, choline most likely is not a vitamin, which is why we refer to it as a pseudovitamin. Choline is obtained from the diet as either choline or lecithin. An average diet furnishes plenty of choline per day, with the recommended upper limit of 3.5 grams per day. Choline serves as a precursor in the biosynthesis of acetylcholine. It is also considered to be a lipotropic agent, meaning it's an agent involved in the mobilization of lipids. A deficiency state has not been identified, possibly because choline is readily available in the diet and is synthesized in the body. The administration of large doses has been associated with sweating, GI distress, vomiting, and diarrhea. That wraps up today's presentation. The upcoming one will be a continuation on minerals. If you have any questions, please feel free to email me, and as always, you're welcome to stop by Pharmacy Plus in Morsani. Be excreted in the urine. Therefore, daily intake of these vitamins is desirable for optimal health.